There we go. Okay, so obviously based on the overview that Jillian provided, our topic today makes a lot of sense. So medical or behavioral, examining the overlap in symptomology.
All righty. I mean, Jillian's case is, it's perfect for this, obviously, with this seizure disorder. You don't want to miss a treatable medical situation. You don't want to certainly miss a treatable medical emergency. You don't always know. In medical school, they always would teach us about pheochromocytomas, which is a unique tumor on the adrenal gland, but I always like to point it out as a teaching item, because what it does is it slowly releases excitatory hormones into the system. So it presents as increased heart rate, sweating, nervous, irritable, a little bit of shortness of breath. So I defy anyone in this room, this virtual room, to tell me if you don't see that in one of our patients that we're thinking, oh my, are they anxious? You know, they're having a panic attack. But no, they could be having the pheochromocytoma tumor. And seizures disorders, of course, are classic for mimicking behavioral health symptoms. And obviously, if you miss a medical cause, things can and often will get worse. And if you pick a symptom that we're presented with, agitation, psychosis, anxiety, depression, you name it, I can come up with a medical cause in the differential. And it's not that I'm so smart, it's just fairly obvious that there's a medical cause in the differential for almost any of them. So what helps us a little bit is you want to get a real thorough individual history. You know, when did these start? How did they present? What's the pattern? And family history is also super important if we can get it. I realize there's some individuals that might be adopted. Some people may not be forthcoming about psychiatric history, but that really helps us to narrow it down. And to just give one quick example of medical first, think about, not one, there's a couple on that list, diabetes. If somebody is hypoglycemic, how is that going to present? Well, it's going to present as irritable, anxious, edgy. And if they're hyperglycemic, overly high on the glucose level for a little bit of time, they could be lethargic, depressed, lethargic, slow cognition. Thyroid, also very classic. We see cases, hypothyroid, depressed, gynecologic disorders, the cycling of the hormones can have an effect. And so can cardiovascular. That's one that's often left out. But if there's poor perfusion to the brain, there could be chronic depression, chronic cognition issues. So we want to keep in mind that all these various systems can have an effect. And, it's funny, we like to joke around, oh, I went for a physical to my doc and they didn't do anything. But, when a physical exam is done, there's some things we're looking at. You're looking at, is there a nodule on the thyroid? Is there a lymph node that's up? Is the skin tone off? Is it dry? Is it oily? There's a lot of little things that, if it's a good doctor, hopefully it is, they are thinking it's not just routine, but what does that relate to? And hey, you've now presented to me with depression or anxiety. So a good physical exam is really important to start pointing us in the right direction. And my last point on this slide, I think is really important. A lot of times it's missed and the person is put on a psych med and they're better. And that's great. But if it's coming from another source, that doesn't mean we've cured it. If somebody has hyperthyroidism and I put them on Klonopin or Xanax and they're calmer, well, that's nice that they're calmer, but I might just be masking it and it's going to come back in other ways. So yes, we want to treat the symptoms, but we want to make sure we look at the underlying possibilities of what caused it, or we're going to miss something.
Absolutely. And I want to point out back to the case Ryan, as Jillian talked about, he didn't really have any of these behavioral health symptoms through his upbringing. And they, started at, his later teenage, early 20s. And, that's a really good sign of saying like, okay, let's step back. It would have been really easy and it was very easy for providers to say, oh, he's at that age, he's starting to have, some major mental health or other aspects. But like Jillian pointed out, the mother was an amazing advocate. It caused a lot of burnout, which we will be talking about, but she really pushed for those, for the thorough medical and didn't just allow them and the providers to consider it behavioral. So Dr. Kent mentioned that thorough review. So a comprehensive medical evaluation is incredibly important. it's not just a simple doctor's appointment, as you can see from this roadmap. We really want the professionals to be investigating everything that they can medically before we kind of move into the psychological. If we are the professionals within a case and we're recommending a comprehensive medical evaluation, we want to support the system in preparing that medical history. And like Dr. Kent said, this includes not only the individual's medical history, but also any family medical history that we can be aware of and dig for, as this is really important for the doctors to be aware of, especially the immediate family members. So preparing the medical history will include current medications, any medical and surgical history, allergies, the symptoms of that specific health issue that is of concern, any recent blood work tests, any names, addresses, phone numbers, fax numbers of any of the specialists seen and the testing that they've completed, information about your diet, the sleep, the eating habits, all of that. The PCP will gather and review this information. They'll gather the current health status, like Dr. Kent said, and make referrals to specialists. During that process, the PCP is that hub of the information. They'll be gathering all the specialist reports and findings and ensure the follow-up is completed. As we all know, as professionals in this field, assistance is usually really necessary and to make sure that all the specialists are communicating and really utilizing your PCP as that hub. So just a quick quote coming from the research. Approximately 80% of people with behavioral health needs access such settings, such as emergency rooms and PCP offices. And as many as 60 to 70% of those patients leave without their behavioral issue being addressed, severely impacting their ability to recover from any co-occurring medical issue. So that co-occurrence is really important. Again, there is a lot of access to providers, and especially in the emergency rooms. And, in START, we look at records with a fine tooth comb, and oftentimes they'll go to an ER, they'll kind of throw on some medication, they'll add a diagnosis after, a very quick review, and that changes the course of that history. So you always want to follow up with the specialist kind of in the outpatient realm as well. So this is really taking a look at Ryan's case. Now, when we started this process, they were still looking at EEGs, and a lot of the neurologic providers were kind of saying like, no, it's just behavioral. And the behavioral providers are saying, we're not sure. Maybe it's just behavioral, but maybe it's neurologic. And there was a lot of kind of just passing the buck, so to speak. But like Jillian said, in December, he finally received the diagnoses of seizures and started getting treatment. But when we started this process for this case, that had not happened yet. But again, looking at the overlap of symptoms and why it kind of fell into two categories. So in the neurologic bubble, we have that freezing, the staring off, being stuck, interruptions to sleep, which was causing, a lot of people saying it's neurologic. And then the attention challenges and the obsessions was kind of what the behavioral realm was pulling on. We could automatically assume, oh, he's having trouble with attention and now he's all of a sudden having OCD. Let's just get him on psychotropic medications. But as we discussed prior, you always want to investigate medical first. Given that these symptoms were abruptly new for Ryan, the quest for a medical component began. And again, his mother was amazing in spearheading that, utilizing the care manager and START services to support her in doing so. As you can see in the chart on this slide, there is an overlap of symptoms between the neurologic and behavioral psychiatric. We can see, some of those attention challenges could be related to seizures, right? Or even the increase in obsessions. It's easy with these symptoms that Ryan was presenting for the specialist to bounce that individual and the caregiver between the specialties without taking that time to truly investigate. And again, it really was the family and the supports that the family were participating in that really forced that process to be in Ryan's best interest. It was very frustrating for the parents. They experienced extreme burnout in this process, frustration, but they knew their son. And they kept pushing on that quest to understand the symptomology from a medical perspective before they allowed him to just fall into that behavioral bubble.
All right, so to go into a little more depth, we were talking a little bit about to work the person up. So a physical exam, as I mentioned, you're looking for any kind of signs of a medical illness. Again, could be a thyroid nodule. It could be, lymph nodes showing infection. And the overlap between medical and psychiatric it's crazy how important it is. And like right now, I have to tell you what I'm seeing in my COVID patients is flare-ups of their OCD, flare-ups of their panic and their tics and Tourette's. And I actually researched it, and I've gotten some data from the American Psychiatric Association that this is being researched and it's going to come out in the next few months. So that, again, the overlap is just so important. So we want to look at timing of symptoms, whether it's not COVID, is there a viral infection? Was there a bacterial infection? Are there particular stressors that set it off and worsen the symptoms? All this matters. Blood work, we want thyroid levels. We want to see a white count to see whether somebody has a brewing sepsis or something else. Thyroid hormones. Diet is super important. Even if the person's not diabetic, I want to know how they're spreading out their food, because they may not meet the criteria for diabetes, but their sugar level may be dropping at certain times. And that person could present with quietness that looks like freezing or something that looks neurologic. And again, I left out on the physical exam. I want to look for asymmetry. Is there one-sided weakness? Are there sensory issues? Are they not feeling things the same way on their right foot and their left foot? Are their eyes tracking properly? So when you look at the cranial nerve exam and you look at a sensory exam, that could also help pick out, is there something neurologic that, that we need to look for? CAT scans and MRIs, very important too in certain population. Are there plaques? Is this the beginning of MS? Are there other things? Is there a stroke? Are there chronic, mini strokes that have added up? Sleep patterns in this case are super important. If the person's not sleeping, that's going to flare up something or cause something. And under antecedents, I don't remember on this case, and perhaps Jillian and Elise could talk to it, but is there trauma? Certain trauma situations can lead to more of a freezing response and to more neurologic symptoms. And then the last thing on this slide, medication history. I do a ton of consults here, and what I always try to get everyone to understand, at any moment, it's a snapshot. So if I hear someone's on Zyprexa 5 milligrams, lithium 600 milligrams, Xanax 0.5 milligrams, that's great, but how did they get there? Has it gone up? Is it now coming down? Are there new combinations? When did one start? When was one added? Because without that, I really can't get a feel. And I've learned from the coordinators to be patient, because it's hard to get that info and the families often are slow with it. Some of them are not overly wanting to share things. And the only little tidbit trick that I sometimes point out is that with their permission, we could get a printout from the pharmacy, and the pharmacy could give you, track the last couple of years of meds, and then we could go through exactly what they were on, when they took it. So sometimes that's a little thing we could add to, to consider for helping.
So Jillian, is there anything to add about any trauma history or anything like that that is important in this case?
So the family have not noted any significant forms of trauma. Looking back at the case, he was young when he moved to gain more supports, and for somebody who was struggling a little bit already with anxiety, that could have been very traumatic. But in terms of reportable, noted traumatic experiences, no.
Thank you.
This slide gets into the neurologic eval, as Elise said, when it goes off to the specialist. And it's important to remind people, neurology and psychiatry are separate specialties, but they're very related. And there's even a push in some circles to try to combine the two, because if your brain's not functioning, it's not just motor activity, it's not just cognition, it's also going to be behavior, right? Because it depends where the brain is malfunctioning. It could be in the part of the brain in the frontal where you're disinhibited, where you're labile and can look bipolar, or it could be in the parietal lobe where your spatial stuff is off. So they're very, very much connected, and particularly ADHD, which this individual has. As you'll see here, there's new classifications for seizures, focal versus generalized onset. Focal, of course, means it starts in a specific area. Generalized, it starts all over the place. Now, that doesn't mean focal can't go generalized. It can and often does. And what happens is then you can have awareness with a seizure, like this individual does, and then it can become impaired awareness where it can become generalized. It's also divided into motor or non-motor, which is important. And in motor, there are different types, and there's too many specifics to get into for this lecture. But the point is, this is how it would be worked up. Do they have seizures? Are they focal? Are they generalized? Is there awareness or is there impaired awareness? And I just want to point out one last thing, which is absence seizures. Absence seizures have impaired awareness, but it's not a generalized seizure where the person is lying down, flapping, and having classic foaming at the mouth and arms moving. It could be as simple as staring into space, freezing, and they have like a little bit of an eye blinking. So I have teachers report back to me if they see that. And then on an EEG, there's a specific pattern of a 3-spike wave. And that looks and mimics ADHD very, very much. But when you give them stimulants, they don't get better. If you give them anti-epileptics, they do get better. So the overlap and the similarity between an absence petit mal seizure and ADHD is very significant. So in this individual, seizure activity may be a component, and it's not that simple because you could have both. So you can't think, aha, I found the seizure, it's all done. No, you have to then treat that and then continue to watch the so-called psychiatric behavioral health part, because you may need to treat both. Okay, so now on the neurologic eval, what are they going to do? They're going to want to see, as the other slide shows, is it seizures? Now, because someone had a seizure, that doesn't mean they're going to have a lifetime of seizures and they're going to have a lifetime of seizure treatment. Best example, little kid has a fever, has a seizure. So their seizure threshold was a little lower, and it may get better with age, but they're not necessarily going to treat it. So they have to figure out, is this high risk for a second seizure? Or in fact, is it a second seizure? And do we want to give a diagnosis of epilepsy? And if they do, they're going to get anti-seizure medication. But what if it's not epilepsy? Is there another medical cause? And certainly there's many. It could be syncope, which is passing out, and that's usually cardiovascular, where you get orthostatic hypotension, meaning your blood pressure is too low when you stand up and you black out. And I want to remind people that work in the group homes, if you see a patient on guanfacine or clonidine or propranolol, which we all love to use because we think it has less side effects, it does, but syncope is one of the main side effects. So that could look like a seizure. You get up, you pass out. The person will describe it, if they are verbal, as feeling lightheaded or blacking out, seeing black. They'll say, hey, it got really foggy and I didn't know what to think. That's what syncope is. You could have an atypical migraine that could present this way. Movement disorders could present this way. Provoked seizures could be an illness. It could be a fever from the illness, vascular, a stroke, TIA, physical trauma, toxic stuff. And when we think about toxic or metabolic, it could even be from medications. Too much medication can make the person have a seizure. I think one of the first couple months I was here, I heard people on triage at start getting all upset that someone's Klonopin was stopped abruptly. Person had a seizure. Well, that's what it was from. It was from the Klonopin being stopped. They did not have epilepsy. So we want to know what that is and treat the underlying cause. And the underlying cause there was a crappy doctor. So I guess then we had to figure out not to go to that crappy doctor and to make sure that the meds were adjusted appropriately. And I just want to throw out psychological causes, because the person could have psychogenic non-epileptic seizures, and that's more of a psychological cause, and you wouldn't necessarily even use medicine. You might treat that with psychotherapy. So you see, there's a lot of, it's tricky with the algorithm to find out, do they have epilepsy? Okay, what type do we treat? Do they not have epilepsy? Okay, that doesn't mean this didn't happen. Is there still a medical cause, or is this purely a behavioral symptom? I think that's you.
This is me. So similarly to the path of a comprehensive medical assessment, we want to investigate the behavioral and psychiatric symptoms in the same manner. It's really important to understand the history for the individual as well as the family, what their psychiatric history is. As we all know, several mental health conditions can present themselves in the early 20s. Therefore, ensuring an individual is not presenting with a new condition or symptom is important. You want to ensure that you're understanding the triggers and the vulnerabilities. What is a trigger? What's causing this? That's what we want to understand. What in the moment is happening that's leading to that behavioral health symptom? What is a vulnerability? A vulnerability is that underlying cause. So like Dr. Kent said early on, if someone has diabetes, part of the diabetes vulnerability might be disruption to mood. With seizures, it might be the symptoms we're talking about for Ryan with freezing and being stuck. So again, it's those vulnerabilities that are innate in that person's diagnoses. In addition, we want to ensure that the professionals that support the individual are utilizing assessments to better understand the symptoms. So in this case, ADH scales, adaptive behavior scales, and even a trauma assessment would be beneficial. We want to make sure that people aren't, and the professionals in the case are not just assuming that it's behavioral or assuming that it's medical. We really want to dig into both. So just like Dr. Kent went through all of the medical tests, the blood work, the MRIs, the EEGs, CAT scans, all of those things that would be happening on the medical side, there's a litany of assessments to understand the behavioral side. We also at New York Star complete an aberrant behavior checklist every 6 months for any enrolled cases. This is something that START can utilize on any enrolled cases to show the changes over the course of every 6 months. So we can compare scores utilizing this checklist and see how things have changed over time. So if we can pinpoint triggers and vulnerability changes and then utilize the ABC scores to also show how those are manifesting.
All right, so if it is more mental health, I wanted to get into a little, what is the person experiencing when they have a freeze response that's anxiety related? So what happens to them physically? They could have immobility, that freezing physical sensation. Change in heart rate, if you were monitoring, is very possible. Often it's raised, even though they're immobile, they may be internally panicking. Muscle tension changes. Fear, perhaps this is if they're aware of being or going crazy and losing control. Definitely a decrease in cognitive ability. This is why they train people in high-risk occupations to go through things like a SEAL team, to get through that type of anxiety-provoking situations and not go into a freeze. So they're not going to be able to do their job, and they're going to put their life and the people around them at risk. Flashback to a prior trauma, which at the end, I'm going to give you a case example that explains that. And with that can come a possible temporary disorientation to person, place, or time. Their focus, whether realistic or not, is on survival. That part of the brain is called the limbic system. It's the lower part of the brain, and it's associated with orientation. It's associated with processing fear and sensory and sending up to the higher part of the brain, which then says, okay, guys, this is what's going on. Let's figure out what to do. But if that part of the brain is frozen, you're not getting the feedback from the higher part of the brain that is logical and problem solving. Now, the case example I just wanted to give real quick, I had this guy, he was a military vet, he was a ranger, and he had experienced ridiculous trauma. Stuff you can't even imagine. And how he came to me was that he was living with his fiance, and he would wake up in the middle of the night in a freeze, and she would go to try to calm him down. And when I say he hurt her, he didn't push her off. He abused her. It was horrific. But she always felt it wasn't him. She always felt that during the day, this wasn't him. Other times it wasn't him. And it turned out he was having this kind of disorientation, dissociative kind of freeze with violent type of reactions when he was awakened from it. So it's a very real thing. There's a lot of different causes. And I just thought that'd be kind of an interesting thing to point out. It wasn't medical. It was this sort of psychiatric. But when you think about the population we have, if they weren't like him or didn't have a fiance staying next to him, we don't know what always triggers it. And they may be at that moment lashing out at the person in their group home, lashing out at their loved one, but they may be experiencing that kind of dissociation and fight or flight trauma and just trying to survive when we think they're just being difficult and upset because we took their cell phone away. Not that there aren't cases like that are very difficult behaviorally, and it's really what's going on at that moment. But it's always important to have a trauma history and keep this in the back of our minds as well.
Absolutely. So before we move into the next section, I want to kind of take a pause and see if anyone has any questions, any comments, any thoughts. Like I said, when I'm sharing my screen, I can't see everybody's picture. So just unmute and jump into the conversation. Okay. So we will move into kind of in talking about integrated care in regards to this topic. So working in silos, it's a really important aspect of the field. So historically, behavioral health and medical health have existed in silos. Behavioral health conditions have not received as much focus as medical conditions. These silos have perpetuated the stigma associated with behavioral health and resulted in unmet care needs, adversely impacting health outcomes and significantly impacting healthcare costs. In 2012, individuals with co-occurring behavioral and medical conditions incurred almost $300 billion in additional healthcare costs. It's estimated that between 9 and 16% of this additional spending could be saved through effective integration of behavioral and medical care, a 26 to 48 billion cost savings. As a result, today, there's a growing awareness that it's necessary to integrate behavioral and medical care to improve affordability, quality, and patient provider experience to achieve total health improvement. Integration can be achieved through appropriate collaboration and coordination between medical providers and behavioral providers, supported by technology, legislative changes, and health plans. Medical and behavioral conditions have high rates of co-occurrence, particularly with chronic medical conditions such as diabetes, seizures, thyroid conditions. A co-occurring behavioral condition impacts a patient's ability to manage his or her own medical conditions, which then impacts the patient's health and increases the cost of care, which is a lot of where we fall in helping support them to manage their conditions. Co-occurring behavioral conditions can increase the cost of care up to 2 to 3 times more than the cost of treatment for patients without a behavioral condition. A serious mental health condition also significantly reduces adult life expectancy by an average of 25 years, generally due to the coexisting chronic medical conditions that often go underreported and undertreated. For patients with co-occurring conditions, it's important to ensure care is coordinated because these patients are more likely to be taking multiple medications, creating the risk of drug-to-drug interactions and introducing other complexities in the treatment plan. One other thing I want to add too, and I don't know if Dr. Kent will have a thought on this, is that, of course, there's a lot of medications that are used off-label in psychiatry, and that may have an influence on a medical condition or vice versa, a medical medication that's used for, could use for mood stabilization, et cetera. And if those two providers are not communicating, you can see a really big change in their presentation or an increase in a medical crisis. Just recently at the Resource Center, we had an individual here that was on a medication for migraines, and off-label, it can be used for mood stabilization. Unfortunately, the mother felt he didn't need that medication and took him off of it on her own. And we've been seeing a very large increase in mood instability and aggression, along with headaches and migraines. So we are working with that system, but I don't think the family recognized that in addition to just taking off the medication on their own being a problem, but how much that medication might have been influencing their behavioral health as well. So again, that's a big reason, another reason why that collaboration is really important.
Well, you stole my thunder. I have a slide on that later.
Oh, we'll go into it deeper then. All right. So how to support providers to integrate. So, this is a really big part of what START comes in to help do. We are that systemic approach where we come in as an auxiliary member of the system. We don't replace anyone. And our goal is to have everybody working collaboratively in the best interest of the individual, to support stabilization, build everybody's capacity so that the crises aren't happening and everyone is able to support them if it does happen. So one of the ways that, we all want to support providers to integrate is through training. So training medical providers, primary care providers, to screen for, identify, and potentially treat behavioral conditions, to understand the role of behavioral providers in the medical setting, to more effectively refer and coordinate care. This can be supported through adjustments to curriculum in medical and nursing school, which unfortunately I don't know if START will have an impact on, but we can go in and do trainings and talk to providers about the need for training and support and provide that to them. Another area is training behavioral providers. So training behavioral practitioners to identify co-occurring medical conditions to ensure a patient's whole health is being addressed and to effectively work in a medical setting. There has been an increase in embedding behavioral health providers in primary care settings. I've seen this quite a bit in the last few years, where a primary care setting will have, a mental health clinician or a social worker in their office to be a part of their multidisciplinary team to refer clients to that they feel need additional support. And they can offer on-site consultations, referral, treatment. There's a neurology office that's in Suffolk County that has mental health clinicians working right out of it that I think is really wonderful that they have that as an opportunity. Supporting referrals is incredibly important. Helping to find and access the appropriate referrals, making those connections. Again, it's not always important just to have the provider. It needs to be the right provider. They need to be able to understand the complexities of that individual, especially our individuals. They are very complex. And then utilizing expertise. So leveraging the expertise of behavioral health providers, social workers, and other health providers to provide training and services that can enable PCPs, specialists, and other medical professionals to more effectively treat their patients. So again, we all are experts in our own individual field, and we are all providers in some way. But we might need to work collectively with our other providers, our medical providers, or our therapists, or our psychiatrists, to really help educate them and support them in not working in silos. While our society's earliest perceptions of behavioral health have evolved as science has advanced, our understanding of behavioral conditions, prejudices linger and can still be seen in modern attitudes. More recently, there have been efforts to address stigma and care inequality associated with behavioral conditions, and several organizations, including the World Health Organization and the World Psychiatric Association, recognize stigma as a significant public health barrier and support initiatives to fight that stigma and discrimination. There have been several acts signed by presidents and through the legislative realm of trying to improve this area. And I do think that the COVID pandemic has brought a lot into awareness of the impact of the pandemic on mental health for everyone, not just people that we all support. And I do think that the need for mental health care has increased and become a little bit less stigmatized.
Hey, Lisa, I just want to add
Yeah.
one thing.
Yeah.
One nice thing I've noticed is that some of the police forces around the country are embedding mental health professionals and starting to send them out on some calls where that might be a benefit. I know the mayor in New York is talking about that. I don't know where that stands, and not to make this political, but I think that's such a great idea, and it kind of follows along what you're saying.
Absolutely. Even in schools. So obviously there's school counselors, but they are very much trained, for the school environment, but a lot of them are now hiring mental health counselors and, clinical social workers to provide more of the mental health side than the school counselors are able to provide. So even in schools, like you said, police departments, I hope that things will be a little bit more integrated moving forward. So there are, of course, barriers to integration. There are several, including stigma, as I've talked about, geographically based shortages of behavioral health services and providers. Luckily, in our area, in the New York greater area, Long Island, we do have a large amount of behavioral health services. Unfortunately, we do have barrier with Medicaid for our population and getting really quality people that take that service. Anyone that is staying abreast of changes in legislative changes, it's now signed into law that licensed mental health counselors will be able to accept Medicaid, which they previously wouldn't. So once that gets moving forward and the process of getting people on the panel happens, there's going to be a huge boost in service providers that are eligible for our population, which is going to be really wonderful. Financial resources is also obviously a barrier. The capability gaps. So again, especially in our population, it's a very specific population. Dr. Kent and I have talked about how in both of our, graduate and for Dr. Kent medical school programs, ID wasn't discussed. It's not a part of our training. We love this field and we found our own training and we embedded ourselves in it. And luckily we've all found providers that have done the same, but it's not a part of training in the professional world. So the capability is really diminished because of that. We really talk about through START and with all the providers we work with that, you could have a neurologist, but do they understand the overlap with ID, with the mental health? Do they have an understanding of someone with autism and moderate ID and how they're going to present? Same thing with, a counselor. Dr. Kent and I are doing a training at a local clinic in February to help build the capacity of the therapists at that local clinic so that they can support our population to a higher degree. So capability is a really important part of the barriers. The legislative hurdles, again, until recently in New York, LMHCs could not take on the Medicare services and Medicaid services, insurance services. So that was a huge hurdle that had to be fought for. And that has been in legislation, I want to say over 8 years. And honestly, COVID was what pushed it through. They realized they needed more professionals that could service everyone. So luckily that has changed in New York, but there's HIPAA rules and PHI consents between providers. And that can also be as a privacy concern. If the individual themselves or their guardian doesn't want information shared, we're now also forced to work in silos. We've dealt with that a lot in START of, a family member not wanting us to have access to the medical providers and not understanding that importance. And then we're all really limited in the support that we can do because those silos won't change.
All right, well, I was going to title this slide, My Chance to Vent, because this is from the doctor's perspective, because everything you say is so true about working in silos and people not communicating. And the first bullet point, silly as it sounds, accept the concept. There are plenty out there that actually don't. We have a fairly infamous neurologist that we work with, and I get referrals from families that don't want to see him anymore. He says, it's not my job to speak to the school. It's not my job to speak to anyone else. I adjust the meds. So there are some people that will not accept the concept. That is not something I think is at all acceptable. And hopefully that's the minority. Because it is our responsibility. It's not a good thing that we do it. It is actually, to me, in your job description as a physician, especially, I guess I was trained child and adolescent, you got to talk to the caretakers, the family, the school. Otherwise, you don't really get much of a picture of how the person is doing. And communicating with the other providers, again, is essential because they're doing different things and they can be at odds with what you're doing. I think it's very incumbent upon the provider to check new medications and keep the list updated because things get added, things get deleted. And if you don't update it, you're adding something new and that may be more things than you even know that they're taking. So a couple of the pet peeve common mistakes is, even in my private practice, people are going to another doctor and they're adding or deleting a med and they're not sharing it with me. So I see a change in mental status. And as Elise said, I don't know, did they add an anti-epileptic? Did they add a medication for their cardiovascular things? And I don't know. So then I'm making a change and I don't know what the heck is going on. The number 2 one makes me nuts. I've had other doctors adjust my meds. They'll say, well, listen, I think this is a little too low, we should go up, but this is a little too high. And if my patient doesn't tell me, I could find out 6 to 8 weeks later, and I may have a mess on my hand and it's somebody else touched my meds. And it's not that I have such a big ego. I don't mind them calling me and saying, hey, let's make this adjustment. And as a matter of fact, I just had a great working experience with a gastro, and I adjusted the Elavil for the person's stomach and their anxiety and their insomnia at night. And the two of us spoke and it worked out great. But I would never in a million years think to do that and not tell them. You just can't do that. And lastly, this just happened to me last week. I love this one. Starting a med, and they'll tell the patient, please ask Dr. Kent if it's safe, but I think so. So, I mean, I'd love to be in a court of law if something bad happened, because that person is screwed. But what if that person didn't call me, didn't ask me? And yes, I will check if it's safe, but they wrote the new med. They have to do that. That's their responsibility, and I should be the one following up and checking. But these are the things from a doctor's perspective that really happen. And that's why, for me, START's always been a good fit, because I never liked this stuff anyway. It doesn't make any sense. So the START philosophy really works very well to try to attack this.
Absolutely. So just another quote that I pulled out of some research. So 94% of physicians believe that integrated care directly improves patient care. 90% believe it's a needed service. So that gives me some hope that, as we are, integrating ourselves as professionals in this field into these silos and trying to pull everybody together, that hopefully the physicians we're working with really believe that integrated care is important, and we can kind of change that mindset that Dr. Kent was just talking about. As Dr. Kent said, there are definitely a couple providers that once we see their name, we kind of just shake our head at the side because we know we're not going to get through to them. And, we have to work through that with the system itself. But overall, research shows that providers do believe in integrated care and believe it's needed. So hopefully we can continue to make a difference in our community. So we're going to move into caregiver fatigue. So Dr. Kent.
Yeah, just back to the other slide. It's interesting. I would be willing to bet 100% of people think it's great to donate blood. I wonder what the number is that do. So
exactly.
I don't know where that study came from, but I'd love to know what percentage feels that they never start a med without checking with another doctor. So it's
exactly
interesting, because I think
they believe in it, but how many actually do it?
Right. All right. Sorry about that. So caretaker fatigue. Basically, if you overdo it trying to take care of a loved one, it's going to take a toll on you, and you could see a state of physical, mental, and emotional exhaustion. Every person means well. They want to be there. They want to do everything they can, but they don't always titrate their own effort in terms of, when am I going too far? When do I need to pull back, take care of myself? And what unfortunately can happen, you can see a change in attitude, and the person can go from positive and caring to getting actually negative, unconcerned, and even resentful, just because it could be so overwhelming, and it's human nature. You can only do so much. So when a caregiver doesn't get the help they need, or they try to do more than they're able to, physically or financially, it could really be catastrophic. The caregivers can become burned out. They get fatigue, stress, anxiety, and depression. And when you think about it, this during COVID makes us think about all of us and our healthcare workers, that we all went the extra step. The nurses on the front line, the pulmonary specialists with the ventilators, and some weren't able to pull back and take care of themselves because there was such a shortage. But we always have to monitor that in caregiving for ourselves and for our families that we work with. And the last statement is super important. We really don't want, and there's another slide, but I'll get into this more. It can't be the only identity 24/7. It's not doable. The person will burn out and face consequences. Yeah, temporarily, it's their most important identity, but it can't become their only one.
Absolutely. So what causes caregiver fatigue? So Dr. Kent, talked about some of this a little bit, but neglecting their own emotional, physical, and spiritual health. So we often experience caregiver fatigue in our cases because it does become their only identity, because it becomes their most important identity and their only identity during the midst of that crisis. And it might be the family system, and it might be the paid supports in a group home, or even ComHab if they are working a lot of hours and really feel that pressure. We often will recommend therapy for the caregiver, or, even I remember one of our coordinators in the past were like, take 1 hour a week to get your nails done. Who can help out for that 1 hour where you can just leave the house, shut your phone off and get your nails done, have dinner with friends, little things like that that really do make a difference. We also have had many caregivers and many families who have neglected their own physical health, whether it be their own medical conditions, cancer, their own, diabetes and things like that, that they've had to neglect their own physical health because they didn't have time to go to the doctor, or they'll do it, when there's time, and there's just never time that they make for that. Role confusion. So, we've had parents actually talk about this in the past too, where, they're no longer able to be a parent because of the level of caregiving they need, their individual and their child needs, and especially when they're not a child any longer. So that role confusion can definitely cause some caregiver fatigue. Unrealistic expectations of what, the caregiver can handle. Lack of control, unreasonable demands, all of these things can cause caregiver fatigue. And one thing I want to point out too is that at times, and we see this a lot with START, the individual may be stabilizing. Their level of crisis is lower. They're not having as many behavioral health symptoms. They're actually doing pretty good, but the caregiver is still very much struggling. I just reviewed a plan this morning that this was shown, the individual themselves was really not in crisis any longer behaviorally. There might be some other things going on, but the caregiver's level of fatigue and burnout and their own need was still as if the crisis is at 100%. So why is that? Are they unable to kind of let go and go back to taking care of themselves? Going back to that last point on Dr. Kent's, that caregiving became their only identity, and they don't know how to step away from that at this point. So we kind of have to switch our focus as a system to supporting that caregiver to kind of moving forward and back to taking care of themselves.
All right, a little more on the fatigue. So what happens to that person? What are they experiencing? And there's a lot of withdrawal into their own head, just thinking about the loved one, thinking about the schedule, getting preoccupied with, oh, my kid gets his treatment at 2, 6, 8, 10, when is the food coming? And they're sitting by the bedside and they're really not doing much else. A loss of interest in their usual activities. They maybe were in a yoga class, or they would see their friends once a week. Irritable, changes in their own appetite and their weight, changes in their sleep, getting sick more often, somatic physical ailments. And if this list is starting to look familiar to a lot of us in this field, it's because it looks like a list of depression. And although the diagnosis might be adjustment disorder with depressed mood or complicated grieving, these people often may need treatment for depression temporarily to try to help pop them out of it. And again, I love to give little case examples. And the one last thing I'll end with, and I laughed when Elise brought up the nail thing, because I had this lady, and I'll never forget this case. I was on oncology, pediatric oncology, when I was training, and this kid was in the hospital for about 6 months, and unfortunately we lost him. It was horrible, but the mother never left the bedside, and I would sit there at night. I was on call anyway, so I didn't go back to the on-call room because I wasn't going to sleep anyway. So I would hang out, I would talk to her and try to get her to get out of that role, and she wouldn't do it. I would talk to the husband. And then I decided to get stupid. I took my prescription pad and I wrote a prescription for her to get her nails done. And I said, this is the doctor's order, you got to do it. She did it. Then I felt a little like, okay, that worked. Then I did a prescription for her to go out to dinner with her husband. She did that. And then I really pressed my luck, and she thought I was a pervert because I said, I want you to have some intimacy with your husband during the month of February. And I said to, listen, you need to keep your other roles. It's not making you less for your child. You will give more to your child if you do that. And the other piece that this lecture is not about, but I think Elise kind of was alluding to it, they may have other kids. And those kids are screwed if this person doesn't step away a little bit and still be a mom or a dad and take care of the other ones. So it's very, very complicated, but we can really help that person try to understand. And the last thing is, often I'll use that silly thing, like when you get on a plane and the oxygen drops and they say, put it on yourself first, because you won't be able to help the other person if you're gasping. So kind of use that example for people, take care of yourself too. But they feel guilty, and I understand it. But it's super important in our role to help out.
Absolutely.
I definitely want to jump in here just in terms to this system specifically. I've had many conversations with mom and dad. Dad was staying home from work for a long time and kind of lost that role in himself as provider and all of those things. And, even when I would speak to mom and I would say, well, I know you work, and she would say, well, that doesn't matter. This comes first. And, I try to explain to her that it is important for her to kind of keep those roles, especially if it's not an emergent situation, like we can schedule our meetings around that or at different times so that you can still do those things. But, these parents for sure have lost that sense of intimacy within each other. And there have definitely been times where even just on a call, they've seemed so overwhelmed that I've stopped meetings and just done some deep breathing with them and then ended the meeting because they were calmer and I just wanted them to have that minute to themselves. I've specifically asked kind of questions of when does, Ryan get home, so that, I don't call them in between those times at least, so that they have those 30 minutes when they first get home to put their things down, to, have a glass of water before, Ryan gets home and they have to do all of those things again. But I think it's really important for all of us to kind of note our biases in these situations too, because I don't think any parent signs on to be a parent for 30, 40 plus years. They expect their lives to change over. And I think that that's really hard in these fields because everyone has different biases and they feel like parents should do whatever their kids need, but they have to take care of themselves too and worry about their own health.
Absolutely. So that is the end of the trading. I'm going to stop sharing and see if anyone has any questions, any recommendations for this case. We did have obviously a change and he has been diagnosed with the seizure disorder. But as Jillian said, there are still some lingering symptoms. So there's still more work to be done. Like Dr. Kent said just now, that because the medical has been evaluated and moved forward doesn't mean that there aren't also behavioral health conditions and things that need to be supported. And obviously the caregiver burnout that we talked about is a very big concern in this case and in most cases. So are there any questions or recommendations for the case that anyone would like to share?
I was just wondering if a sleep study would be beneficial at all.
Has a sleep study been done?
Yeah, they did a sleep study at the hospital. Nothing was noted at that time. That was while they were also doing the EEGs and those kinds of testings.
Yeah, we often push for a cheapy version of a Fitbit to sometimes, if the person isn't able to go for the sleep study or it's too hard to get them there, whatever, that can do that. Yeah, and look at how much time do they have in restorative sleep, how much time are they up, because that's huge. I mean, it lowers the seizure threshold and obviously it lowers the threshold for behavioral health symptoms too. So that's very important.
And now that he's starting treatment for his seizures, it might be worth repeating a sleep study to really ensure, there have been changes in that area, or positively or negatively, and really make sure we have a really clear understanding of what that stands like at this moment now that treatment has changed. So that's a great idea, Eileen. Thank you. Sean, I did see that you had unmuted. I don't know if you had something else to add.
Yeah, thank you. Can you just repeat what you were saying about the social workers and the medical?
So it's specifically for licensed mental health counselors. So previously to this legislation, licensed mental health counselors were not able to bill for Medicaid or Medicare services. So they were not able to take on those clients. But it was about 2 weeks ago, maybe 3, that went through the governor's office and is getting implemented now. So in New York State, licensed mental health counselors will be able to apply to be on the Medicare, Medicaid panels, and then be able to take those patients. So it will change things for this population and for all people to have a greater pool of providers from LMHCs. Previously, only social workers or psychologists were able to bill for Medicaid or Medicare.
Is that just for private? Or
nope.
Okay.
Clinics, private practice, anyone with an LMHC will be able to get on the panels now.
Thank you.
You're welcome. Okay, if there aren't any other questions or comments, Jillian, can I turn it over to you for any things that you're gonna make sure to bring back to the system?
Yeah, and definitely, I just heard Dr. Kemp say Fitbit, and I actually think that that's a good idea just for their future monitoring for the, I think it'll be easy for them. I think it'll actually help mom, put her mind at ease a little bit. So I am gonna recommend the Fitbit idea for
I
sure.
actually, in that, does he ever fall when he freezes?
No,
Okay, because I was gonna say that maybe if, I know it's a higher expense, but the Apple Watch has that fall detection. So if he
Yeah.
fell, it could actually bring emergency services to him. So that may make them feel a little bit more comfortable.
yeah.
But if he doesn't fall, then that's not
Well,
necessary.
that might
but-
just be helpful because their son is sleeping alone now, and maybe it could give him an
Yeah.
an hour. I'm
Yeah.
saying Apple because I'm writing Apple Watch.
Yeah.
An hour alone.
Mm-hmm.
So
Yeah, because he can call for emergency services right by his phone.
Yeah.
If he does happen to fall, if that's something they end up being afraid of, it will literally ask them if he's okay. And if he doesn't answer it within 30 seconds, they will send emergency services to his location. And it also does the sleep monitoring. So that might give them some peace, even if it's not happening at this moment.
Absolutely. I'm definitely going to bring in the companion dog idea.
Yeah,
I
that
think
was great.
that was a fabulous idea and definitely something that I think that they'd be very open to actually. And I'm going to suggest that they do another sleep study now that they are on the new medication. It's been a little bit of time and maybe kind of see what is going on there.
Have they been back to the behavioral health providers now that he's stable on that medication to really evaluate the continued symptoms? So
No.
so that's definitely something that now that they have diagnosed the seizures, but there are still some, OCD like symptomology and obviously the anxiety symptomology that is still occurring, that is still impacting his independence. So now might be the time that the medical has been evaluated to kind of go back to those providers and do some of those assessments. So an ADHD assessment, an OCD assessment, and really get a clear picture now that the medical has been clarified.
Definitely.
Yeah, they might want to look at adjusting the Klonopin, spread it out so that the anxiety is reduced and doesn't cause more of those seizure type activity, because that could be one of the antecedents that we were talking about if he gets very anxious on top of it.
Absolutely. Absolutely. Definitely some good thoughts.
Yeah.
Obviously, like I said before, we started on this quest for the CET when it still was not clarified and they had not diagnosed the seizures, but there's still some work to do, given that there is symptomology still lingering that impacts his independence. And like Jillian explored, his independence was really important to him. It's important to the family's well-being. And it's definitely something that we want to support him getting back to. So definitely some really great follow-up. So thank you, everyone. Is there any last thoughts, questions, or comments before we end? Okay, I'm going to take the silence as a no. Thank you, everyone, for joining us. This was a really great topic. I hope it was helpful to all, and good luck with the impending storm. So hopefully everyone stays safe this weekend. Thank you all, and we'll see you next month.
Thank you.
Thank you.
Bye, everybody.